Is that too bright in your face? Sorry.
We'll make it work.
Okay.
Oh, star. Okay. So for prox, you're gonna forget this eventually. What we want to do for prox is we actually want to be really high on the sternum and get it through that liver. If you go subxiphoid, which isn't the end of the world on some patients, but that's when you're going to get that angle. So we're going to be really high up on that sternum. When we do liver, you're going to stay on that sternum. I'm going to say, no, we got to go below and push and scoop. So it's kind of two different windows in the same area. And then by the time you get to full abdomen, you'll forget that you ever had to do the on the sternum. I'm like, why is your air not horizontal? Come on now. Alrighty. So what's my first image?
Sagittal prox.
Sag AOP. You got it. Oops. So, oh, actually, let's do IBC first because we don't really care about him. Okay, so how do we determine IBC versus aorta? One touches the liver, right? And one doesn't. So I have this guy right here, and then I have this guy right here. Who's who?
That one's IBC.
You got it. Let's go TGCs down just a little bit. Come on. What did I do? What is that? What did I do? I don't know what to do. Run harmonics. Okay. I hate this machine. Well, I don't hate it, I'm just not very used to it. Okay, so focus down, at or below, right? Why do we do that?
Better image quality.
Yes. And why is it better image quality?
Because it's an hour.
The ways to the hourglass. So for IBC, go ahead and big breath in and hold it. What we want to do is we want to show it under the liver as elongated as possible, and we're going to show it with the right atrium. So we don't need the entire right atrium, we just want to show that it's patent to that right atrium. We're going to sweep it for pathology, go ahead and breathe. And oftentimes we don't see it very well past the liver. But we've got a nice open lumen, swept for pathology, so that's your IBC picture. He's pretty straightforward.
And that's one you won't have to do. Like, you don't need this picture.
Not to write up
for
requirements
the-
and applicants, yeah. Okay, so now we're going to cruise to the aorta, Sag AOP. So we got these machines last year and I haven't worked with them very much. I've taken the summer off, so I do a lot of this. But okay, so then we're going to move over to that aorta. So he's going to be a little bit deeper, more retroperitoneal, and he doesn't touch the liver. So go ahead and big breath in. So we've got our proximal aorta. Now you'll notice that it has an angle to it. So I want to make less distance between the front of my transducer and the aorta. So I'm going to rock that transducer forward. You can see that then it makes everything horizontal. I've elongated out as much as I can across the screen. So we're going to take this as an image. And then we're going to measure this. So how do we measure these guys? Outer to outer. So you wouldn't want to measure maybe in here where you don't have a very clean wall, or down in here, but since we have a really clean anterior and a very clean posterior wall, that's a good kind of neighborhood. And so I'm going to lay those crosshairs right on that outer portion, and then lay the other crosshairs right on the posterior portion of that. We want to be as 90 degrees as we can. 90 degrees as we can, so we aren't elongating that out.
And do you need that whole liver?
So prox is under the liver. So it's going to live there.
So, I mean, is the aorta not supposed to be towards the middle of the screen of the picture, or?
You mean depth-wise?
Yeah.
So we have enough depth that we're seeing any retroperitoneal lymph nodes, things like that. This is spine down here. And so we have an appropriate amount of depth because if we got rid of any more, we wouldn't be able to see if there was pathology.
Up?
You can't get rid of up.
Okay.
You can go deeper or shallower, but you can't get rid of up. There's a thing that we can do called zoom, like zoom into things. We won't worry about that right now. But nope, we're good to go. Okay, so who's my next image?
Sagittal AOP with color.
Yes. Okay, so now we want an angle, right? So we're gonna relax our hand a little bit, so go ahead and big breath in. So then now we had that more natural angle. Before we had to push the front of our transducer to get horizontal. Now we're gonna have a little bit more of a natural angle. I push my color button, and go ahead and breathe for a minute. So it's gonna set me up at 15 centimeters per second, which is a little bit low velocity. And so there's a button over here called scale. So that's our PRF, our scale, our velocity. So we're gonna raise this up a little bit. And these machines are notoriously terrible at color flow. These two are amazing at it. So when you guys are doing your protocols and you need to get color, try to get yourselves on those machines. Okay, big breath in a little bit again.
You said you want the angle.
Yes, we do want the angle. Let me get a little bit of that. Yeah, these machines are just notoriously terrible at this shit. They're an echo machines, so they're not really made. So we're not getting much color flow here. Okay, pretend we are. Pretend it's happening. Okay, good, breathe. Yeah, we're pretending. Okay, yeah, we saw that color flow, right?
Maybe it's not enough. 19 not enough.
Well, it should be, if anything, it should be higher than that. So if it's not picking up 19, it's not going to pick up 30 or 50.
Ah.
Does that make sense?
And if you
When we get to the mid and stuff, it will be easier. It's the prox that's usually tough.
if you reduce the thing itself, will that help to kind of
Nope.
no?
Because it's where the settings that are important are here. This is just how much of that area we're looking at. So even if I made this really tiny, it's still the same settings. So it's like if I'm looking through a little tiny tube, I'm still seeing the same thing if I'm looking out, you know, at bigger things. It doesn't change it.
If we can't see it, should we touch the settings? Should we from 19 to 17?
Yeah, we can try that, but honestly, I know it's in their shape.
Okay.
Yeah, I know it's in their shape. They're just, we had this problem with the other lab. Because it's picking up flow at our portal splenic confluence. It's just not picking up anywhere. I don't know why. Who knows? It's just the way the machine works. Pretend we got a color image, okay? And we'll try for one here on the mids and stuff. Okay, so now we're back to our 2D. So who's next on our list?
Transverse
So we're going to hit our transverse, and we want to make sure we're kind of stay under that liver. Go ahead and big breath in and hold it. So here we are under the liver. We've got IVC right here is touching. See how I have some gas clouds over here? So I'm going to move towards the right side of my patient to scan back towards that left. And remember how I told you those lateral aspects can be a little bit difficult to scan, to see, to visualize? So we're just going to use our best ultrasound eyes. The other thing we can do is we can decrease our image width. And that's going to take these lateral beams and just kind of aim them back this way.
Show us one more time how we did it.
On this machine, it's called priority. On the other machines, it's called image width. So whatever this machine decided it wanted to be called. Okay, so we're going to go ahead and small breath in here. So we're going to see our aorta. She's got pretty clean walls. They're not refracting out too bad. And so we could actually have a little bit better spot to put our calipers. But sometimes we just don't see those walls very well. Okay, so then our transverse AOP. Okay, who's up next?
Sag mid.
You got it. Are you seeing a pattern here? If we do Sag, and then we do transverse. Okay. So Sag AO mid. Go ahead and big breath in. So here we were, where we were at our prox, and then this is kind of pancreas. We're not seeing clear SMA, so we should go just kind of past the liver a little bit. Now this area loves to get a big bowel cloud. Can you guys kind of see it's kind of cloudy? So we're just going to give her a little bit of a push and sit on it for a second to try to elongate it out as much as we can.
We see splenic vein. Is it?
Portal splenic confluence and
Confluence.
transverse. So SMV, IMV are coming in this way. This thing's going this way towards the portal hepatus. It's going that way towards the splenic splenic vein and panc head. Okay, so Sag AOM. Take our image, calipers. I've got some clean wall right in here to measure. We know that we're at mid because the SMA interacts with the pancreas, and we're at pancland.
So would you take it just past the liver?
If you couldn't see pancreas, yeah, just kind of the middle of the neighborhood. So there's our Sag AO mid. And what's next?
Color.
Color. Okay, go ahead and pick one. Hold on. Okay, so let's see if our color friends are working out today. Yeah, these machines just really suck. Let's go color cleanup. Thinking about it, but no. Then we're just seeing a lot of tissue artifact. Okay, pretend we got a color image.
Sorry, could you pretend where it on this place would be renal arteries? We don't see them. But
We don't see them. So they
But-
would be somewhere between the pancreas and I would say probably this neighborhood.
And SMA somewhere over here.
SMA interacts with the panc. So SMA is going to be kind of right. Here's our panc. Where this go? Let me turn this off here. So here's that SMV, IMV coming in. So at the level of the aorta, it's going to be somewhere in here.
Okay.
So that's porta splenic confluence, and then it's going to be coming between here. And then that left renal is going to go right between the two. So we're looking kind of somewhere in the middle of this. Okay, and we did get a little bit of color flow in the IDC for whatever reason. Okay, so who's up next? All right, so we're gonna go transverse. I'm gonna decrease my depth a little bit. Give him a little bit more star of the show. I'm gonna decrease my, where are we going? What are we doing? Where's my priority? Decrease my image width. Maybe go 2D down a little bit. Because we don't have the liver anymore, we're just kind of dealing in bowel land. Things get a little bit bright. Maybe one less click of depth. Here we go. Walls aren't quite as clean as they were at the prox. We just didn't have that nice clean window that we had with the proximal. So we're just going to use our best guess.
How did you deal with the gas?
Push. You just push. Well, the
decreased?
transverse, I went over to the right and scanned over, and when we were in Sag with the mid, I just pushed, and you can just kind of wait it out. Okay, who's next on our list? You got it. Now you notice I had to get rid of some depth because this is getting a little bit more superficial.
I have a question when you measure for transverse, right? Because they're changing their how do you say pulsating, right? So
I'll try to get it at systole, where it's the widest, so that I'm giving them worst case scenario, so you'll see it kind of pulse, and so I try to catch it when it's the widest. And not that there's a huge amount of change in it, so if you had like a better image when you were in diastole, you could do that as well. Okay, Sag AOD, I'm really covering up here. Okay, where do we go? Where do we go? So here we go, we're gonna go all the way down to the distal. And you guys remember that image that we had a few minutes ago in the lecture? How it's gonna be wide and then it's gonna taper down, see how narrow it gets? So that's where her iliacs are coming off. So we wanna make sure we're using our distal. It looks like an old lady finger. So since we are tapering at iliacs here, we're gonna take a look at them separately. All we need to do is worry about our distal. So distal likes to be coming a little bit more uphill, whereas our iliacs like to go downhill. So our iliacs may fill with one color and our distal may fill with another. Totally okay. Let's get horizontal. We've got nice clean wall to measure. I'm gonna back it up to systole. So back it up to where it's the widest. Take that image. Calipers, outer to outer. Got nice clean wall here. And maybe we'll do like kind of right in here.
would you also decrease the width of it?
Not for Sag. So Sag should be as elongated as possible. For transverse, we can do that.
If we're standing really on the middle, could we say which is right, which is left iliac?
So we'll get into that in just a second.
Okay.
That's going to be usually where the bottom of your transducer is pointed. If it's pointed towards your left leg, your left iliac. If it's more pointed towards the right leg, your right iliac. Okay, so next up, let's get some color on this bad boy. We might have better color flow because we're more superficial. Where I lost it. Where do you go? Where do you go? Okay, so let's get some color. Come on, color. Oh man, there we go. You did it. So see how it's going like red to blue, red to blue? It's telling me like, look, idiot, your machine settings are off. So I'm going to take that scale and I'm going to increase it. until we get kind of one color. And let me do this.
Aliasing? Could you say it in English?
Aliasing.
Aliasing.
Is it next? It's next. Let's open this up just a little bit. So now we're, okay, here's what color fill really looks like. You see we're still getting a little bit of that blue.
Mm-hmm.
So we're gonna go scale up maybe one more. And so we are at 48. So you're gonna be kind of in the 48, 50 neighborhood, depending on who you're scanning. And we wanna make sure our color's filling. Now notice this goes through the box, it's not getting cut off by the box. And we're about a third of our image width. We finally got color. But the sequoias are gonna be much better for color. Okay, so then we're ready for transverse. A-O, oops, I made this lowercase. Okay, we've done this before. I have no idea, it was my first day. Okay, so going into transverse. Now what is my next step to image optimize this?
Decrease the width.
Decrease the width, you got it. So we're gonna decrease that width. You could maybe go 2D down. The other thing we can do is, okay, so see how we have like this bright fascia and everything else? We could also drop our dynamic range, and I'll show you. And that would just make the aorta a little bit more anechoic, but it also brightens up everything else. So helpful sometimes, hindering other times. We'll go kind of back to our soft tissue settings. Okay. Sending back to where the nice round systole. Putting our calipers on. Saving our image. Now for iliacs. Let's open our width back up. So there's one way you can do iliacs to figure out who's left and who's right. And that is, we're gonna slide down this distal, and then this is eventually gonna bifurcate. So here he is, and I'm gonna hit her belly button. We're gonna kind of ignore that. I'm gonna ignore your belly button. Okay. So here we are at the aorta. Let's kind of get rid of some of our depth. And so it's gonna go from one circle into two circles. So one circle, and then you see how it splits into two? So there's our bilat iliacs. So it looks like a little frog face.
Transverse.
Correct, yeah. So you can always use this and then just follow one of them to determine whether you're on the left or the right. Or you can go to this, so here's our distal. See how it's gonna taper to an iliac? And is the bottom of my transducer more pointed to her left leg, which is right here, this is her left. It's very subtle. Or my transducer is more pointed towards her right leg. So in this case, it's gonna be my sag right iliac. And where's our caliper? Why do you keep going back to text? How do I get back to text?
And on the picture, we pointed to the left. Left would be higher on the picture.
No, not at all. Nope,
at all?
not. It's just the way hers went. It went higher. It's going to be all about whether I'm angling towards the left side with the bottom of my transducer or angling towards the right side. Because keep in mind, this is like a V in here, right? They're bifurcating. So here's our distal, the top of our transducers in our distal. So we can go slightly towards the left. So the bottom of our transducer is towards the left. We're going to go slightly towards the right, and the bottom of our transducer is on the right. So it's kind of one or the other. Okay, so let's find him again. So you can do, what did I push? What is even happening right now? I'm gonna guess. Well, our settings got all reset for some reason. So here was our transverse. Ooh, less tab. What just happened? Okay, so here we are at our distal. I'm moving just slightly inferiorly, and then we have our two little frog eyes. So we've got the spinal process, we've got these two little eyes. So we could follow one of those. This is that sag to transverse, which is a little bit tricky for you guys right now. So what I would recommend doing is kind of sitting on that distal aorta, and then see where it's tapering, and then move the bottom of your transducer one way. And does it lengthen out? I'm gonna really push in here. Does it lengthen out one way? So my bottom of my transducer is towards her left leg. Or do I go this way and it lengthens out this way, so the bottom of my transducer is towards her right?
It's left.
No, This is right. So I'm looking like this right now.
Mm-hmm.
So I won't see left until I move my transducer over
Okay.
there. And then it will look identical to this, but it will just be on the left. The only time we see both of them is if we're in transverse. Or if we're for some reason sitting on top of each other.
Uh-huh. And when we be sitting on top of each other.
They barely don't do that.
Okay, got it.
Carotids will do that, but these guys won't. Okay, so let's get our caliper outer to outer. Now we have kind of a little bit of a downhill going here, so we're going to have a little bit of an odd angle. We want to make sure we're 90 degrees to that iliac. So we're not going to be, we had that horizontal aorta, so things were pretty top to bottom AP with our calipers, but since this guy's starting to dive down, our calipers have a little bit of an angle. Okay, so what's next for this guy? Color, you got it. Now, whereas we had the aorta before was going to be red because it was going towards our transducer, as I kind of heel toe this, I can make this go red or blue. So right now, where'd you go, little buddy? So right now it's going away from my transducer, it's going towards her feet. Or I can angle it, so I can do this right, this direction, and it's going to be red. So it doesn't matter to me, whatever is easier for you is fine with me. So it's getting nice and blue. And then this is iliac vein under here.
Are you measuring the right and the left, or the bifurcation for the color?
I'm at the iliac. I'm actually at the right iliac.
The right iliac, we're measuring the color for that.
Well, I didn't measure the color, I measured the AP, and now we're putting color on it.
I mean, to take a picture, yeah.
Yeah, yep. So you'll need sagittal color with it as well.
We don't do color on transverse.
No, because we want to look for flow abnormalities in length. Plus, if I have my two, all I'm getting is one small slice of that vessel, whereas here I can see a longer length of it. I mean, it's not, you could if you wanted to, but like, so say I had a plaque and I did color and sag, then I could do color and transverse just to show where that plaque is, but typically we're going to do it in sag. Okay, so then instead of doing our bilats right now, we're going to go our transverses for the right. We're just going to go straight into the sag left. Okay, so here's that distal again. So we're at the bifurcation. See how it widens, then it starts to narrow. So I was over here a second ago. Let me get that little bowel cloud out of there. I was over here a second ago, so I'm going to angle the bottom of my transducer towards that left side and lengthen out that left iliac, which is not as much length as we got on the right. See if we can come back. So I went over to our left side just to angle back a little bit, see if we could lengthen it out. And there's the left of the length. So we have our distal here, left iliac. So we can get a little cleaner. So we're going to caliper him, outer to outer. We have a little bit of an angle because he starts to dip down. And then we're going to get some color on him. Where'd he go? I lost him forever. He's gone. Disappeared. Sold him. Sold him on eBay. And then again, that's going away from the transducer, so it's going to be blue. Oops, I dropped it. And iliacs are a little bit more tricky to lengthen out just because they're so tiny. So even if we only get a smidge of it, because we're not really ruling out pathology in the iliacs, we're more trying to rule out pathology in the aorta. So next we're going to go, instead, so we did sag right, sag left, and now we're going to go transverse bilats. So that's going to be that frog, that's going to be that little frog picture. So distal aorta, nice circular structure, come down, starts to bifurcate, we get these two little eyeballs of the frog face. We have two options here, so we're going to take our image and then we can just measure them on the same image. The only time we wouldn't want to do that is if one of them's like zoom, going off the other way and kind of oblique to what we're doing. Okay, how's that feeling for you?
So far.
Okay, I'm going to leave you gooped up.
Okay.
Somebody wants to take over? Keep me